COVID-19. Before these restrictions, a person with COVID-19 could infect 2.5 persons in 5 days, 406 persons in 30 days. When you put into practice measures to reduce the exposure activities by half of that one infected person, in 5 days you would possibly only infect 1.25, 30 days, 15 persons. Reduce the exposure of that infected person by 75%. In 5 days, you infect 0.625. In 30 days, 2.5 persons. Remember, the virus does not move on its own. People move it. The more space between you and others, the harder it is for the virus to spread. A health and wellness message from your Ministry of Health. If you have been directly exposed to the new coronavirus or have a history of travel in infected populated areas, it is recommended that you self-quarantine. Identify a room to be used to self-quarantine and limit contact with healthy persons. Keep away from older persons and persons who have medical conditions that affects their immune system. Monitor for any cold or flu-like symptom for up to 21 days and wash hands frequently with soap and water. If you become seriously ill, call your healthcare provider or 0800-664-2273 for guidance. A health and wellness.
Good afternoon. We're going to be doing another segment, health-related segment on question and answers, and on the Ask the Experts, as that's the name that's been given today. Now I think it's a weekly kind of 1-hour session that we'll be having, at least from the health standpoint. We had said that last week, Monday, when we were here. But primarily, there's two main topics we want to address. One is the issue of COVID-19 in the region, and then I'll ask Russell to discuss how the surveillance actually happened and what the groundwork entailed in terms of being able to contain a first, some people say we didn't have a wave, or the first sporadic or cluster of cases. The terminology that we use can vary depending on the epidemiology behind it. But we are now into our day 38 of having confirmed the last 4 cases. Since then, we have not had any other case. I don't think we have had any highly suspect case. We have been screening anybody who was showing up in the health system, and it can be both public and private, that has a severe acute respiratory illness or people who have influenza-like illnesses. The numbers in both of these are not really that high. We do have cases, we acknowledge that, but they are not really coming necessarily to the flu clinic. I was in Corozal and Orange Walk yesterday, San Narciso as well, to see how the flow of those flu clinics go, and we are not seeing that high number of cases that we had been seeing at the beginning of the year. Nonetheless, we have been continuing to do swabbing and testing of samples, and certain elements of random sampling has happened. In terms of what's happening in the region, Mexico and Guatemala, which are our immediate geographic neighbors, continue to report cases. Mexico has now had indicated that the 29th of May, which is next week Friday, would have been their estimated peak date. That, again, changing dynamics of the disease, they are now moving that to a later day in June. Interestingly, what the Mexico numbers are also showing is that they are having a higher hospitalization rate. In average, in other countries, it's usually around 20% of cases go to a hospital. That's 1 in 5. Mexico is close to 33%. That's almost 1 in 3, which is a higher number of cases. Interestingly as well, and this can explain how quickly your system can be overwhelmed, is that they have not been able to test everybody who is ill inside a hospital. So that you're having patients that are dying of severe acute respiratory illnesses or atypical pneumonias, and they are not necessarily being tested and diagnosed with COVID-19. Guatemala is also having increasing numbers. There are more than 2,000 cases. Last weekend they had a 3-day almost complete lockdown, but on Monday everything went back to almost normal, and the amount of people on the street was significant. So countries in the region, except Costa Rica, are having increasing numbers. We are now starting, I think the official numbers will start to come through now. For Nicaragua, that's starting to have more deaths associated to COVID-19. In terms of risk factors, because this is a changing situation, we can no longer say it's only affecting certain age groups. You will see reports coming that young adults can be equally infected and be in a hospital. Babies now having rare syndromes which has been associated to viral infections. Kawasaki's disease being one, Guillain-Barré, which have been associated to other viral conditions. But it is important for us to stress two items in there. Chronic diseases such as diabetes, hypertension, and obesity are significant risk factors for complications related to COVID-19. People who are heavy smokers and have permanent lung damage, the chronic obstructive pulmonary disease patients have also having a higher risk for complications. People having congestive heart failure. And obesity, we must underscore, seems to be a significant risk factor, because even in younger adults who are obese or teens who are obese may have a poorer prognosis than people who are otherwise healthy. So that's important. And the other item is, notwithstanding everything that's happening in terms of treatment, there is still no specific treatment for COVID-19. There are advanced stages or phases of vaccine trials, but still nothing significant. And the new data over the last 24, 48 hours suggesting that even if there is a vaccine, it's still not known how much of an immunity response it can generate, so that we would not know how much protection you can get from a vaccine. And in terms of the COVID-19, also specific to what's happening in terms of testing, we're still not finding any specific rapid test that is way ahead than the others out of the more than 70 that are being studied. So for now, we remain with PCR testing. Depending on what we find for the rest of the week and maybe next week, going into June, we may be scaling down the populations that we are testing. I think we're going to have more targeted approaches in terms of who we screen for COVID-19, given that they are not having significant signs and symptoms. And one final note before I ask Russell to talk about the surveillance aspect is that in the visit to the facilities, people keep asking us, why do we continue to procure PPEs? Why do we have items listed that we want to procure? Is because we need to continue to prepare. Yesterday in our social media post, I did show an empty hospital space inside the Northern Regional Hospital that has 6 beds for COVID-19 specific cases, where they're testing booth, where their flu clinic, which had known, at the time I was there was nobody at the flu clinic, even though you have a doctor and 2 nurses that were there. So that needs to continue to be prepared. Those facilities will remain there for whenever we have any potential cases. Corozal also has 8 beds now. They are almost complete. Of course, as we go along, you try to improve your facility, but at least those 2 entities were set, and I believe also that the flow of traffic in terms of cargo primarily that was coming through the border from Mexico onto Belize seems to be a fairly smooth transition process, where there's a mutual understanding between Mexican truckers and the Belizean truckers picking up the cargo, where there's no interaction really between humans. They are just unhinging the cargo truck, and the new truck that's coming from the Belize side picks up and brings it into the cargo area on the Belize side. So the 20-30 minutes I was there, that's a very smooth and well worked out process that works Monday to Friday for certain hours only. So We will continue to do visits to different facilities. Minister Marvin and CEO Goff are further west today. I have been myself to Independence and Nangriga, meeting with staff and with management teams to see how we can have this completely set up for whenever any new set of cases comes about. So I'll ask Russell if you can talk a little about the surveillance component of what we have done in the first cluster or sporadic cases that we had, and how that transitions into whenever we have any new investigation to undertake.
Sure. Good afternoon, everyone. Indeed, the entire, I guess, the scenario globally, when you talk about how do we curb the numbers or flatten the curve, what we're talking about is ideally what it boils down to is surveillance. When you're talking about testing, identifying, isolating, the containment of those cases is essentially what all of this needs to be done globally. For us, when we started hearing the first news coming out from Asia, specifically to Wuhan, we had started our own, alerting our own surveillance teams here of the news that was happening on that side, and we knew that after the spread to other countries, it was something that because of travel and mobilization, it eventually would have ended up in this part of the Americas. Just to touch base that when I talk about surveillance focal points, it means that these are individuals who at some point have been trained to do outbreak investigation. That means that here at the ministry, we have been holding for the past, I believe, 10 years, 8 years, a field epidemiology training program that is geared to health providers, basically nurses, physicians, public health inspectors, vector control, and recently we had even had participation from the Belize agriculture as well. So people from Baja were in this part of the program. In addition, we actually had individuals from the military who were also part of the program in itself. So what we're trying to do is to train these individuals who would be our, well, I know DHS has been mentioning the foot soldiers, but they're our eyes and our ears on the ground. That means that these individuals have the capacity to actually conduct an outbreak investigation and follow these cases, which includes contact tracing, isolation, and everything with that. So pretty much when we started this entire scenario, these individuals were called upon to revise their plans that they had in the regions, just to make note that we had been working with our influenza plan, which means that there was already a plan in existence for influenza, and we go back to the years when there was H1N1 SARS situation, and these were measures that were already put into place in the regions. When this happened earlier in the year, around February, we started holding our face-to-face meetings with them to go over those plans and see where we needed to work at. I know by the time our cases started coming out and the first cases came out in the other regions, we actually had our first case reported on the 21st of March. By then, we already had our team set up in the different regions. A team is composed of physicians, nurses, public health inspectors, and because of the need, we also had vector control. So with that, each one has an identifiable role to play in the teams itself, so that when they go out and do these kind of case investigations, then each one knows what their role should be. In this response, we knew the first cases were in San Pedro, and of course the measures there was immediately put in place of a lockdown on the entire island, which of course could have done a lot of mitigation with that. Individuals who were out there actually knew their role, that what they were supposed to do. I guess I just want to highlight as well that individuals from the surveillance teams should be commended for the tireless work that they did throughout the entire time in the beginning. I mean, from February, we have been working with them days and nights that they would start preparing their plans. When the first cases came around, then actually they knew what they had to do. The work, of course, expanded then that they actually had to continue with contact tracing. Just to touch on contact tracing, it is something that you need to inquire from the individual who has tested positive that there is a series of walkthroughs that you need to do with that person. You need to find out daily what they did in the past. I know we talk about incubation period of 4 to 14 days, so we need to go back and find out the history of that person. That means that you need to inquire their travel history, where they were, who they came in contact with, what they did on a daily basis, their routine activities, and what else they probably held in some social gathering. That is actually it's an exercise and it's a map-out that you do day by day, that you need to look at those processes and the individuals who they came in contact with. To mention to you that contact tracing also goes by tiers, that it is not actually everybody who are high-risk individuals. Individuals who are in your household or who you work with directly throughout the day, these are the individuals we would consider the highest risk. Others are those that probably you come in contact occasionally, and they would be classified as a medium to low. And then you have the casual contacts, who might be somebody that you hail across the street or you run into at the store. These are, of course, individuals at the lowest risk. So based on those measures, and of course, testing would be done by the risk groups. To mention again that these individuals who do the screening and the testing are the same ones who are actually on the ground every day. So every day they have some work to do in the fields. In the beginning, we had a lot of work to do with paper-based contact tracing. That means that these individuals would go out and be filling these forms and making sure that everybody was captured. Then they would go back, compile, and create a database for us that we could follow every day. Pretty much that extended into February, March. By then, we knew that we had to do something to make it easier for everybody. One, to facilitate the surveillance in a real time so that we can get that kind of information on a real-time basis. But apart from that, we also wanted to have individuals not be exposed to the paperwork and everything else that was coming along with it, which we knew would be something there that would have created a hazard for these individuals. With that, we already were probably into our 4th and 5th case that was being reported. By then, we actually knew that we would need some assistance, and we got some assistance from the Statistical Institute of Belize, SIB, to see how we can actually look at ways or innovation of how we can get targeted a more real-time response. Of course, our team here at the ministry knew what we needed. We knew what were the questions and the variables that we wanted to follow. And of course, with that, we had approached SIB to see how we can measure, how we can do it. We do know that the Ministry of Health does have some very capable individuals to actually follow through with it, but in this instance and the particular situation we were in, we started to reach out to the SIB. The SIB has been very helpful in creating different applications to follow with surveillance. I believe a lot of it has been highlighted already, but I just want you to know that a lot of it, it does come down to surveillance and how we want to manage the cases. We do know that in countries that have managed to curve that or flatten that curve, there's a lot of technology behind it. But the technology behind it in itself is, what do we do with surveillance? How do we use the surveillance behind that to actually further identify those cases, isolate those cases, test them, and actually start the mitigation process. So indeed, there were different applications that came out that we did that we are using. I guess just to highlight some of the few that we do know of, we have, for example, to go back to when we're talking about contact tracing and these individuals are doing it on a manual basis. Along with SIB, the creation of a persons under investigation mobile version was created. We had the indicators that we needed. We worked along with the SIB to see how we can get that. Of course, there were tireless nights that they invested into the creation of that mobile application, and we did have assistance with the tablets that are now being used by the surveillance officers. This now is a version that they can actually go out and do contact tracing of those individuals under investigation without the use of paperwork. Ideally, what it does, that after you do a contact tracing, that kind of information that is being collected can be gathered, and once it is synced or synchronized at the end of the day or whenever you have the Wi-Fi available, we here at the ministry will actually get it in real time. The SIB also facilitated, along with the team here, the creation of the dashboard where we could follow those individuals as well in real time. Our purpose was to identify those individuals and see where the need to assess those individuals would be by region. The purpose behind that as well was to facilitate for the regions by risk group how they would do their surveillance with those individuals. That was one. Of course, the EOC here that was created, the operations center here was receiving calls. I mean, in the beginning, there were hundreds of calls that were coming in. And to do the triage of individuals that would be coming in as well, that was something that was being looked at. Again, we reached out to SIB to see how we could make it easier to get an application of how individuals would be calling in and be triaged so that they can actually be tiered or triaged into different groups. That was something else that we looked at, and now it is created. We also been working with the SIB to look at another component for surveillance that we used in preparation for other health. I guess it is for health systems and see how the bed capacity that we'd be using. It has been finalized a couple, I guess a week ago to see where we are. What I'm talking about is a modeling aspect to see a modeling interface that has been created to look at when we have outbreaks again and to be able to give a forecast of how the situation might look like in the country. Fortunately, the DHS had mentioned that that we have been over a first a wave, if you want to call, but when we look at it individually, there were sporadic clusters that were given in that first wave. But to use a modeling system, you really need to have more data. You need to have more numbers to be able to forecast and see what the need or how the situation would be in the country. Fortunately, because of all the measures and restrictions that were put in place, we're not seeing any of those numbers. Though the director did mention that we still are doing surveillance and still doing testing. We have been expanding our surveillance to cover key or high-risk populations at this point. I guess, I'm not sure if we mentioned it before, but we are looking at individuals who have come in contact with a lot of individuals. For example, our frontline personnel, which includes not only healthcare providers, but of course the uniformed services, the police officers, the BDF, Coast Guard, individuals who have been in contact with a lot of individuals. Of course, the DHS had mentioned as well about key groups that have been affected. We are looking at those individuals who are coming in with influenza-like illnesses and severe illnesses as well. At this point, even though we don't see the increase of numbers, we are able to screen all of them that will come in. He did touch on a point though that he's saying that the numbers are not being seen, and I think this is something that we revised. We do want to make mention that perhaps what is being seen is that we know that the messages is that if you are sick, if you are ill, that you stay home, that you call, and if you want if it gets any worse, then you call and then you seek a consultation. I mean, this is something that we've been seeing in other regions as well, that the numbers of influenza cases is not as high, but this is something that is being looked at as well, that perhaps because of the messaging and the restrictions and the limited movement between people, they're not accessing services. Now, I perhaps would just want to mention there that we want to make clear that even though you are ill and you're managing it at home, if you are seeing that you are not getting any better within a few days, then you need to call and you need to ensure that you get that service provided. So the numbers are still there. You can call 0800 MOH CARE, and now we do have the screening application tool as well, that if you do not want to call in, you can use that application tool that is there to get triage, and then we can follow them by regions, and then somebody will be contacting you. So it is at this point that we want to mention that if you are with a flu that is not improving, then please call the number or go online and you can fill out that screening process. Somebody will get in contact with you for that. We also want to touch base that when we talk about high-risk groups, we do know that they are very vulnerable groups who are at highest risk. What the DHS mentioned earlier was indeed, in fact, key groups that are being affected is still being present, but now it is being seen across the board from very young to the elderly. However, we're still seeing that there is a higher risk group there. And as part of our surveillance, we're also looking at even our own elderly and nursing homes. So as part of that surveillance, we have been screening staff who are at those homes and assisted living. We will go further to even screen individuals who are at the homes to ensure their well-being as well and that they are screened and tested. This is a measure that we have been included in our expanded surveillance. Going through to that, we do have some risk groups. Of course, we won't be able to screen everybody. That is something that globally no one can do. But of course, we want to look at key risk groups. Going forward, we will start looking at our revised case definition of who would be screened. But at this point, in these coming days, this is how we've been doing it. I guess apart from that, the entire process of surveillance now that we're going a little bit more with mobile and the electronic versions of applications, indeed is to assist us in how we would respond rapidly and efficiently, moving away from the paper-based and now being able to follow through in real time. We believe that now with these applications that have been supported by the SIB, this is something that we want to actually get a hold and a grasp. So we're fortunate that this time that has passed or elapsed and we haven't seen those numbers has actually prepared us to be able to look at those applications and see how best we can use them. Our surveillance officer, Nurse Perez, is actually out right now in the fields in preparation and meeting with surveillance teams to see how we would manage when we start looking or considering reopening the borders, or in this immediate case when we're talking about repatriations. With repatriations, I know yesterday in this session as well, CEO Burns had mentioned the different algorithms and procedures and how it would be carried out. But I believe in the end to all of this, the surveillance and the contact tracing and the management is indeed when health would need to take charge and ensure that these measures are put into place. It is an entire process for the repatriation that there are many ministries that would be involved. There are still certain things, so Nurse Perez is out there actually meeting with those teams to ensure that these things are in place for our side from health, to ensure that the teams know what to do when these individuals are entering the country again. So I believe just to wrap up with that, we do recognize that the need to go with surveillance now is indeed is made easier on us now that these applications and electronic versions are there for us to work with. I know that further discussions are being made to see how we can track individuals who would be entering the country, but that's in discussion yet. But of course, we're open to all those discussions as well. Thank you.
Okay, thank you, Russell. Now that you're talking about data as well, in terms of chronic diseases, it's important that we say that in one of the last studies, and it's not a recent one, said that 1/3 of Belizeans were obese and the other third was overweight. So that only 1/3 of the population is actually within a healthy weight, if you will, or body mass index. So that means that already 2/3 of Belizeans would be in a pre-morbid condition to be at risk for COVID-19. 13.9 prevalence is what I recall for diabetes. That's an old study. That's diabetes. That doesn't talk about pre-diabetes, which can be a significant amount of the population, and hypertension as well. One of the census data from SIB talks about 1 in 6 Belizeans who knows that they have a chronic disease and for which they had been prescribed medication. It doesn't necessarily mean that they were taking the medication or well controlled, but that is there to underscore how severe a problem we can have, which is the same thing that's happening in Mexico, which is why they're saying 1 in 3 people are in a hospital is because of all the chronic conditions. So we have all those chronic conditions. So this is the opportunity beyond hand washing, physical distancing, using a mask, is starting to do exercise, because we are a very pre-morbid condition kind of situation. So I will start going through the questions because I notice there's a significant amount of questions and all kinds of and types of questions actually. This is Cancun has a relatively high incidence of COVID-19. How will this impact Belizeans returning home through Cancun, whether using hotels, public or private transportation? I think it's not only Cancun because people will be going through 1 or 2 airports before they get here. So it's wherever you're coming from. When you look at numbers, the US has significantly higher numbers than Cancun. And what we always are recommending people now is go through the process rather quickly. Find the shortest route home, minimize your interaction. If you don't have to stay in Cancun, you just go into the bus. I mean, you won't be able to be picked up there. Or some people we know have paid private transportation, especially those medical condition patients, to come directly to the border. And again, this all has to be in a planned, structured kind of way so that you will find the shortest route to getting here and making sure you minimize your contact with others. That the importance of physical distancing needs to be stressed more than the mask. It seems that of late we have been concentrating a lot on the mask. We assume that it's because there's a fine that's pegged to that, but it's really the physical distancing. So the fact that you have a mask doesn't necessarily mean you can get closer than the recommendation of the 6 feet situation. Can one contract the virus through secondhand smoke? Not really, not the smoke itself, but I would assume that if you're smoking, the fact that you can be doing an aerosol procedure where you're expelling items, not only the smoke, droplets, that can put, if you are infected, then you can put that in a room where that can expose others potentially. It is mentioned that the second or third wave is expected, or clusters or whatever. The reason why we actually started using the term wave, because I know Russell had said we never really had a wave, is so that people could understand what we meant, that we had this first group of cases or cluster or sporadic cases, but so that people could understand that eventually we can have a bigger number or bigger numbers whenever they start to come again. It says, can you please enlighten us as to where the second or third wave will come from exactly? Will it be most like once again imported? It's going to be imported for sure if we don't have any case right now, and I think it's pretty safe to say we don't have a case right now. We don't know. For now, it would seem that it's going to be through one of the land borders, simply because there's still illegal trade happening. When it's a legal kind of process, you can detail it more, you can follow it more, track it easier, as the good work that the epidemiology unit has continued to do from the beginning of the year, that will remain. Is it possible that the vaccine we get as a baby is helping us to boost our immune system against COVID-19? And I'm assuming that it's going to be talking about the BCG vaccine, which we have a 95% on average coverage rate. There's some suggested data that says that there might be a protective barrier with that, but the studies are not that extensive. This vaccine is not widely available in more developed countries. Then they don't put it in their routine vaccine schedule, for example. In the US, you are not going to get it routinely. We do 95 to 97% coverage, but we are unable to say that that is the protective factor against COVID-19. And our numbers, as Russell has said, are fairly low to be able to do comparative studies with other places. What is the plan to deal with patients in rural Belize where they were they to be affected by an outbreak? Will they follow the same channel as any patient that requires a hospitalization? I mentioned being in 2 areas yesterday, Orange Walk and Corozal, and I stopped by San Narciso. San Narciso, for example, has 1 bed basically where they determine what they're going to do. Their referral, for example, would be to Corozal. Corozal has 4 beds, hospital beds, and Orange Walk has 6. And so it would be determined if you are from a rural community that you require a hospital, then you're going to be taken either to Corozal or Orange Walk, depending on where your flow routinely is. Is MOH concerned about how quarantine locations are being safeguarded by security forces? That's a trick question, if you will. My concern is the interaction with any potential suspect case with the general public. And I guess this question is because of the 3 persons that jumped, that escaped from the quarantine facility in Corozal. Now, these are Mexicans. We would assume they quickly jumped and ran across the border. I don't know that they would be interacting with anybody. So in that sense, from a purely public health standpoint, that those that jump would not be a concern. If we have a highly suspect case that escapes, then that starts to become a concern. Understand that we, in a quarantine facility, our job is to look for the health and evolution of the person that is there. We are not necessarily going to be the ones providing the food, providing the toiletries, the security and all those elements. That's work that's being done with police, NEMO, immigration, and the other departments. I'm asking, based on present resources, how many swabs is our capacity per day, and how many tests can be conducted. We can do 90 tests per day on average. Well, it can do probably more than that, but that's where we would put it. And what's the number from Fuvencia? Total number of tests that we can do for now?
For now, we're close to 8,000, 8,500, something like that.
Yeah, it's closer to 8,000 as I would recall. I had seen 6,500, but supplies keep coming in on a weekly basis. So we would have the ability to do 8,000 tests. Again, and this is important because I have seen lots of people who I guess are doing epidemiology studies or mathematical studies or statistical projections saying you're not testing enough. We discussed this at length. I said last time, Monday, and after that we met with CARFA during that week, that no country in the region is really doing random testing the way we are in the general population. So they're basically doing more targeted testing. There's not a magic number or a specific number of population that you would need to test to determine that you're in point of fact free. That is determined by your epidemic. And we don't seem to have any highly suspect cases out there that are not being tested. So I can't tell you that if you test 15,000 out of the, or 20,000 out of the 400,000 that we are, that's what, 5% of the population. If that would be an automatic number, because, okay, that's 20,000 now, and when would you need to test those 20,000 again? That's important. We don't have that figure then, and I don't think any country or any model has that figure. What advice are you giving about reopening schools, especially primary schools, since children are about 3% of infected cases worldwide? We had a first discussion with the Ministry of Education, CEO, and other managers of the different management systems in the school last week, Friday, and there's one tomorrow afternoon, virtual session, because there's many unknowns in as you reopen. For example, one of the topics I discussed with the Ministry of Education was what happens with the schools that are in the Cayo area, for example, that have a huge influx of people coming from Melchor and further along all the way up to Flores who come to school on a daily basis. I don't know that when the school opens whether that will be possible. And I think we need to be able to inform the people on that side at this point in time. Yesterday when I was in Corozal, I found out that there's people who come from Chetumal also to school here, but the numbers are about 10% of what comes from across the Guatemalan border. Again, I don't know that that is going to be a possibility right now because we can't safeguard people that are coming from outside. That's one of the topics discussed. The other was masks, whether we will be asking young children to wear a mask. One of the recommendations that came up on that day, and again this is an evolving process, was that children perhaps would be more likely and perhaps safer for them to use a face shield, because that allows for a better breathing process, and also it prevents younger children from touching their face if they have a face shield as an option shown. We discussed that schools would need to have better hand washing stations, better cleaning of their bathroom facilities. The school calendar may change. We had tossed out the idea of them opening in August even, or earlier, July if you will, because your entire system is thrown out. Because if you're thinking you're going to have bigger numbers towards the end of the year, then you might need to start earlier, because you might need to close sooner in and go to different cycles as we go along. We discussed about the idea of maybe only having key subjects being taught, having morning and afternoon groups, so that you only have half the population, or half the population goes Monday, Wednesday, Friday, Tuesday, Thursday the following week, and you rotate that cycle. Again, this is us throwing out ideas to Ministry of Education. That's not going to be our call, but we are trying to do this guided by public health, how we can do that situation as we move along. Is MOH in consultation with MOE about protocols to hold CXCs in July? That CXC is a CSEC? Is it the same thing? I don't know. We did get asked about that, and these are some of the discussions we are having. That's part of the discussion we're having tomorrow afternoon to see how we can bring about that and ensure that the physical distancing is kept at all times. Can you please tell us what standard safest mask filters we can use that are available at home or in Belize? Will baby wipes or microfiber cloth work? Well, I don't know that we have asked for specific filters to go in masks. The mask is simply your major barrier. If you're out in the public, that should be more than enough. You should not be using any specific filter for that. Do you have a figure of doctors who work both in the private sector and public sector who have had to stop their private practice during the SOE? No, I do not. I did ask yesterday in Corozal or in Jawak how that was being affected. I was told that all the staff that is in Corozal, almost none of them, well, I don't think anybody who is a medical officer in Corozal said they were engaged in private practice. In Orange Walk, it seemed to be only specialists, but that had apparently stopped during the SOE, but I don't have a number. St. Lucia is opening up to tourists. Once persons arriving have a negative test taken within 48 hours of travel, but the test is usually a paper that comes from a lab, which someone at the airport would have to physically check, when most carriers are trying to move to contact-free travel. Can you comment on whether a provision like this is suggested for Belize? I don't know if you want to answer that. I mean,
no. I guess it's something that's still being discussed. Tomorrow, actually, we have a meeting with Civil Aviation, BTB, and the Airports Authority to discuss on measures that would be implemented on visitors returning. Belizeans as well, to see how a mobile application can be used to track those individuals and how the screening of those individuals would be. Of course, when we're talking about screening of visitors, it is something that we are seeing not feasible, as we're seeing thousands of visitors coming in, and to be able to do any kind of testing would incur a very huge cost on the economy. Of course, they're mentioning of other countries are mentioning of an immunity pass, just to highlight that there is not an immunity pass or passport that should be considered or in discussion, because we are still looking at that of how the virus is working. There is much going on with this virus. It is very fluid. There is a lot of research going. And as was mentioned earlier, it tends to look at, you might not even build an immunity towards COVID-19. Individuals have been developing antibodies, but it doesn't guarantee that you are immune. There's a possibility as well of perhaps being reinfected. We're not sure. So to talk about an immunity pass or to talk about screening individuals who would come in, there is still that possibility that even individuals who are asymptomatic might test negative and might still come into the country and might still be walking around, possibly that can transmit the virus as well. So a huge part of it is how we do control, how we do contact tracing. So there is a need to work a lot with BTB, the tourism, that sector, to see how we can get that tie-in, that buy-in to actually get visitors to do any kind of reporting and for us to follow up with those individuals. I guess I didn't mention, as part of surveillance as well, we do have a surveillance with the tourism sector and hoteliers currently that has, it was launched perhaps 3 or 4 years ago.
2018, November.
Okay. So that was actually to manage visitors who are coming into the country, to report any kind of illnesses during their stay. Of course, well-being to the tourists themselves, how to get access to any services needed. But of course, it was basically for our population and our safety of our population in the country. I know this is something that we were not mandated to do with them. It is not something that they were required to report. But I think at this point now, given the current situation, this is something that needs to be revised. It is something that we would need to discuss with them to see how reporting of ill visitors or individuals who stay at the hotels can do that reporting for us to follow these individuals as well. So I know it is a project that is from CARFA in different member states, and this is something that even CARFA is in discussion as well. So those discussions have started, and I believe tomorrow there's a meeting with those key individuals as well.
Okay, it then says, how are you responding to the letter from the Gym Coalition? It talks about sanitary measures for reopening gyms. Would you recommend that gyms be opened? I did get that letter on Sunday night, I believe, and I passed it on to the Oversight Committee Monday morning. Now, that doesn't address all the gyms. I think it's only about 9 or 10. The key question there is, how do you go about regulating gyms and ensuring that what you are placing there is in point of fact what is going to be adhered to. Once you're in a gym, there's sweat, there's people might be breathing with their mouth open, there's aerosols being produced. That's the key situation. People can socialize, people have music, touching their gadgets, touching all the equipment. And I know there's measures. I mean, we have been to gyms where they give you the specific towel that you're supposed to clean after you leave. People can go and shower, all those things, but it's not really adhered to. Now, these are the gyms that seem to be much more structured, but how do you then go about controlling all those other gyms that are not part of this coalition? And to be honest, in health, that's the key concern, is we don't have the human resources to be manning all the quarantine facilities, all the hotels, all the restaurants that are now starting to open, and how you keep that social distance aspect. Talking about gyms, I know the question came up about churches. We did not get a chance to address that. I can tell you that in the meeting we did ask from the Council of Churches if they would have more or less a census of how many churches there are in Belize. In the community where I live, I think there's about 15 churches, and there's 2 restaurants. But you see, it might, this is not only an economic situation. Restaurants are easier for us as a public health to be able to regulate. Why? Because you might need your food handler certificate, you need a license, you are registered, you need to meet certain requirements. But nobody seems to know in the community where I live how many churches there are, when they congregate, how many people go to the congregation. So health, again, cannot be going through all of this process of mapping out where all these facilities are. And this is talking about you gradually opening up. We're working with people who have a more structured kind of audience and time, like schools, and it's still a difficult question. So I have read the entire extensive thing that the gyms are saying, but we are not that clear how that will be kept, how they will be kept in check, how they will determine, will they work by appointments, will they have 2-3 people in one closed space. Most gyms that I know are with the AC. Remember, restaurants, for example, are not supposed to be open if they have an AC. It's out in the open. The same principle that applies here then. So I know we want to say people go out and do exercise because we all need to exercise, or else you're going to be a patient down the road. But we're going to have to get creative as we move along. Can you speak comparatively about the current and past volume of calls to your helplines? It keeps changing. I think the calls are still coming. I think it's mental health components that are being addressed. Of late is the repatriation process. And the other issue is repatriation process, but also the quarantine measures. People, how you come about, what's the process, the cancer patients that are starting to come in. All those are the questions that are coming to us, but it still works. There's still a 24/7 phone line. It's still being manned by the good information officer, Mrs. Claudette Dakers, who phone keeps ringing. So if I have mentioned her name, so if you don't get your call answer, you have to blame her. The employees who can space up space out for 6 feet or more still need to wear a face mask at work the entire time. Depends on where you are. If you're in a closed environment, you more than likely don't need that. If you're just sitting in front of a computer and you're not constantly talking, there will not need to be a face mask, especially if you're not interacting with the public. Like in the closed space where I am here, I know there's ample space with the people. That's why I don't have my mask. My mask is right here, but I'm not wearing it right now because everybody else around me is wearing a mask. Can you please share what steps will be taken, what will be done from the MOH end as it relates to the responses and prevention for the first repatriation flight? Well, one of the conditions that we asked for is that we need a census. That's one. We need to know when people are going to be coming in, the amount of people that are going to be coming in, especially if it's going to be coming through the airport. And even if it's not going to be to the airport, if it's going to come through the land border, we will ask that that specific group or whoever the amount that is decided to come on a specific day comes at a specific day, a specific time, and we have all your data. So upon arrival, you will be go to a quick questionnaire, quick temperature check, because we are going to assume that all of the people are asymptomatic. If they have any sign or symptom, then they will more than likely be swabbed there. They will still all proceed to the quarantine hotel because this is going to be a controlled, it's not going to go to a quarantine facility. And you will be there for 14 days, where our job as health is we will go and check up on you once a day or call you once a day to determine how you're doing. At day 14, we need to go and check, take a swab. If you are negative, you will be allowed to leave the quarantine facility. If you are positive, then that becomes your day 1 of 21, and it leads to the next question that we have. Or if at any point in time before you get to day 14, you start developing any sign or symptom of the flu, you will be swabbed. And if that is negative, then you continue your day 14. You have to be swabbed again before you're let go. But if you are positive at any point in time, that becomes day 1. And that is the difference between 21 to 14 days. 14 days is for people who are asymptomatic coming into the country, and will screen you at day 14. We are saying 21 days, and you will recall why we had said 14 to 21 for those who are already positive or the close contacts of any positive case, simply because the majority of our patients were not seroconverting, which means they were not negative at day 14, and that's why we went from 14 to 21 days. What is the logic for not allowing exercise in the evening? I don't know that we did not specifically want people to exercise in the evening, but the difficulty we had there is, and again, trying to kind of have a more controlled kind of situation. Not that we want to control populations, because we are being accused of that with the curfew, that we want to control situations. That's not true. I mean, the more time you give out, the more difficult it is for everybody who is stretched thin to keep a grasp on that. Again, this might change, because I think as we move along, as the oversight committee meets, you notice we have been gradually scaling down in terms of the response. So eventually I think this will go back to being normal, but maybe what this would mean is it's less hot perhaps in the evening. I mean in the morning than in the evening, so it might be better if we go out and do exercise in the morning, if you will. How many persons are currently in quarantine in Belize? Where did they come in from and when? I know there's people in PG. Those are Belizeans who were caught on the Guatemalan side, handed over, and Guatemalans caught inside Belize are in PG. We have people in the quarantine in San Ignacio at the Victor Galvez Stadium. I know of 7 at last check. Orange Walk now, Lamanay Landing, and the IT vet should have opened this morning because of the 2 persons that they caught illegally. And the Mennonite group from Shipyard should be at Lamanay Landing under the 14-day quarantine. And Corozal also has that IT vet. These includes the Belizean who was on the bridge, and some people who had been caught crossing illegally. I believe there were 2 Belizeans on Tuesday caught.
And
so
all these individuals are screened.
Yeah, they have all been screened. And these are people in quarantine public areas, because we also have all the cancer patients that are routinely being quarantined at home, and some of them have been swabbed as well. Not everybody, but some of them have been swabbed. So that's the end of, I believe, the questions. I know some of the questions get lumped together, so don't feel, I mean, we hope that we have been able to tease them out. We should be running samples today. I think the results are coming out anytime now. How many samples are there today? 70. So you will notice that from when we last detected a case to where we are now, it's about 40% more tests, I think, since the last case, so that we are continuing to do what we had said we were going to do with the testing. We will be here maybe next week. The one other situation that we are following closely is the dengue cases. I did ask specifically in Corozal about dengue, because it can give you fever and symptoms that can sometimes initially could look like a potential COVID-19 case. But continue to be on the lookout for information. We are not, I think part of what we keep trying to address in the multiple interventions we do is understand that there's a new norm. I know that eventually you might be a little bit more lax with the wearing of a mask if we don't find cases, but understand that a mask, you might need it down the road, so that whenever you have more cases, it becomes more of a routine. And I notice we are getting more creatives with the masks. People are having more colorful. People have masks that match their shirt, hopefully their ties soon. That kind of thing. So, and maybe the analogy that I had not wanted to talk about, but it's like when we started talking about condom use in Belize, and I said, condomize the country. It's the consistent chronic use of condoms. That's, I think, where we're going to be headed with masks. It's going to be a consistent, chronic, and appropriate use of a mask, because if we don't know how to use it properly, then we're defeating the purpose of using it. So we'll be back next week with a topic and information as it evolves, hopefully 1 week from now. One other thing before I go, based on the WHO report from earlier this week, for the region, Belize, and I did check because we kind of forget French Guiana, Belize is the only country in mainland America, that's from Canada all the way to Argentina, that remains with 0 active cases of COVID-19. Suriname started their counting before us. They had 10 or 11 cases initially, and they had gone 44 days without a case, and they had a new imported case, so they are back to now day 2. So Belize remains the only country in mainland America that doesn't have any active case of COVID-19, and it really depends on all of us to keep it like that. So thank you very much.
You and others, the harder it is for the virus to spread. A health and wellness message from your Ministry of Health.